Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Hello, my name is Peter Strouse. I'm a pediatric radiologist in the section of pediatric radiology at CES Mott Children's Hospital in the University of Michigan. And today we're going to talk about pediatric elbow fractures. I have no disclosures relative to this presentation. At the pediatric elbow, it's important to know normal relationships, the normal ossification centers, and understand that there are common fracture patterns that we commonly see that aid us in making the diagnosis of fractures. And we'll go through each of these patterns in this presentation. There are 6 ossification centers at the pediatric elbow, which appear in a normal, predictable order of ossification. The most important application of knowing this order in this mnemonic is that the medial epicondyle comes before the trochlea. Therefore, if we see the trochlea, we should see the normal medial epicondyle at its normal location. There are 2 normal relationships that aid us at the pediatric elbow. The first is the axis of the radius. So regardless of the position of the child and the projection of the image, the axis of the radius should go through the capitellar ossification center. The second important relationship is the anterohumeral cortical line, which should go through the middle of the capitellum, reflecting the normal anterangulation of the distal humerus. Supracondylar fractures are the most common pattern of elbow fracture in children. These vary from subtle buccal or green stick fractures, as we see in the middle, to complete transverse fractures, as we see on the right. This is a child with an obvious complete transverse supracondylar fracture of the distal humerus with medial and posterior displacement of the distal fragment and overlap of the fragments. 3 to 5% of children with displaced fractures like this have associated neurovascular compromise. However, that is not something we typically diagnose on imaging. This is a less severe but still fairly obvious supracondylar fracture of the distal humerus. In this case, we see a partial fracture line anteriorly, cortical buckling posteriorly. There is displacement of the fat pads indicative of an elbow joint effusion. Here's a subtle supracondylar fracture of the distal humerus. In this case, we again see the fat pad sign indicating an elbow joint effusion and calling our attention to a possible fracture. In this case, if we extend the anterohumeral cortical line, it goes along the anterior aspect of the capitellum, indicating there's posterior angulation of the distal humerus and a subtle buccal supracondylar fracture of the distal humerus. The lateral condylar fracture is the second most common fracture pattern that we see at the pediatric elbow. These fractures vary in severity. They can be incomplete and stop at the growth plate, as we see in diagram A, in which case there's no displacement of the fragment, or they can be complete, essentially a Salter 4 fracture, where the fracture goes through the cartilaginous epiphysis and we see displacement and angulation of the fragment, indicating a complete fracture and a need for operative fixation. This is a displaced lateral condylar fracture of the distal humerus. We see at least 3 or 4 millimeters of displacement and malalignment of the fracture, indicating that this fracture goes through the cartilaginous epiphysis and this child needs operative reduction and fixation. Note that the soft tissue swelling is predominantly lateral with a lateral condylar fracture. These are subtler lateral condylar fractures, particularly the one in the middle and the one to the right. We see a fracture line paralleling the distal humerus. There's no displacement, which tells us these fractures are incomplete. They stop at the growth plate. These children are therefore treated with a cast as opposed to operative reduction and fixation. Children can also avulse the medial epicondyle. There are 2 main mechanisms for this injury. One is dislocation of the elbow, and the second is a throwing adolescent athlete, as we see here. Typically what happens is the child's throwing and they have acute pain and point tenderness at the medial aspect of the elbow. We get a radiograph and we see the displaced medial epicondyle, as we see here. If you're not sure if the medial epicondyle is displaced, you can always get a comparison AP view of the opposite side, and here we clearly see that the affected side shows displacement of the medial epicondyle, as well as some associated soft tissue swelling over it. Whenever you have a skeletal immature patient who has an elbow joint dislocation, you want to look for the medial epicondyle. In this case, we see a well-developed trochlear ossification center. We should see the medial epicondyle at its normal location. We don't, so we look for it and we see the displaced medial epicondyle projecting within the joint. Oftentimes, when these dislocated elbows are reduced, the medial epicondyle ossification center is trapped within the medial joint space between the ulna and the trochlea, as we see here. So this is something to specifically look for in the post-reduction radiographs. This is a somewhat challenging case in an infant. At first glance, it appears that the proximal ulna and radius are malaligned with the distal humerus. But if we look closely, the radius is actually aligned with this small capitellar ossification center in both projections. However, the capitellar ossification itself is not properly aligned with the rest of the distal humerus. It should sit more laterally here in the AP projection. It should sit more anterior on the lateral projection. So this tells us that there's actually a fracture between the distal humeral metaphysis and the capitellum, rather than a dislocation between the capitellum and the radius. Diagrammatically, we see it here on part B. There's a Salter 1 fracture between the distal humeral metaphysis and the distal humeral epiphysis, and thus malalignment of the capitellum with the rest of the humerus. This is a little bit more challenging example of the same thing. In this case, the infant's so young that the capitellum is not yet ossified. We have a sense that the radius and the ulna are malaligned with the humerus, though we don't see the capitellum to help us make that diagnosis. This is a great application for ultrasound because with ultrasound, we can see the cartilaginous epiphysis. And the arrows show us malalignment of the epiphysis with a metaphysis on the affected left side with widening of the intervening growth plate, consistent with a Salter 1 fracture of the distal humerus, whereas on the right, the epiphysis and the metaphysis are normally aligned without evidence for fracture. So-called nursemaid's elbow is a traumatic radial head dislocation that typically occurs in toddlers with a pulled elbow type mechanism. This is a very common injury that is usually diagnosed by a pediatrician or an ER physician and reduced without imaging at all. However, if you were to get imaging, you'd see what we see here, which is that the radius is malaligned with the capitellum, so we have a dislocated radial head compared to the other side where the alignment is normal. It's important to distinguish an acute radial head dislocation like we just saw from chronic or congenital radial head subluxation or dislocation, as we see here. Clues that this is chronic are dysmorphism of the proximal radius with a rounded or bulbous contour, as well as this bowing of the proximal ulna in this patient. It's important to diagnose this and distinguish it from an acute dislocation because this will not be reducible. Radial head dislocations also occur in conjunction with ulnar fractures, the so-called Monteggia fracture dislocation, as we see here. It's important to remember that when you see abnormality of one bone, there's often abnormality of the other bone. So look carefully at both the radius and ulna. This is another example of a Monteggia fracture dislocation. In the center, we have an oblique fracture of the ulna with a displaced Salter 2 fracture of the proximal radius. And on the right, a so-called celery stalk type fracture of the proximal ulna with a non-displaced Salter 2 fracture of the proximal radius. So if one bone's abnormal, look at the other bone. In conclusion, pediatric elbow fractures are fun. They're also challenging. Aids to reaching the proper diagnosis are knowing the normal relationship of the bones, knowing the order of ossification center appearance at the elbow, particularly that the medial epicondyle comes before the trochlea, and knowing and expecting the common patterns of injury so that we can recognize and diagnose them. Thank you.